So that may be the bad news for some people with very busy schedules here. You need some time to talk to people, although I would argue that you don't need hours and hours of time to use psychological approaches, but it's sufficient if you take a few minutes during a regular doctor's visit to address some psychological concerns the patients may have. I think one of the key advantages of psychological approaches is that those approaches teach patients to help themselves. So we are trying to teach them behavioral skills that they can apply in their personal life to improve their own situation. And this is especially helpful when there are cases where you can't really find a medical cause of a sexual concern. So one of the goals for my talks today is to spark some interest for psychological approaches and to enable you to consider some aspects of mental health in your daily patient care. And please note that I changed some slides, so it may be that some of the slides you have in your booklets may be different from the one that you see today, but feel free to approach me and contact me afterwards if you are interested in the updated slides. Okay, let's start. The first lecture will focus on mental health and the relation of mental disorders to female sexual dysfunction. This is the agenda. I will first talk about the prevalence of mental disorders, and then I will introduce a few concepts that we use to distinguish mental health from, and talk about how it relates to sexual dysfunctions in women. And finally, I will point out some common patterns of comorbidity and explain how certain mental disorders relate to sexual dysfunction in women. First, I'd like to do a quick check-in with you and just would like to see some show of hands. Who of you already has some training or background in clinical psychology? Maybe in a course at university? One person, okay. Everyone else? Okay. Mm-hmm. One person, not nobody. Okay, and who is regularly seeing patients with mental health problems in their medical practice, in the clinical practice? Anyone? Okay. Okay, a few more. Okay, thank you. And what would you say, who is practicing some form of counseling or psychotherapy in their medical practice? Okay, thank you so much. Again, one person. That's good to know. Okay, so I hope that you may benefit from the talk today and maybe have some ideas how to approach mental health concerns in your clinic as well. This is one of the slides that I often use to start my lectures, and I start by telling my students that 50% of people are affected by mental illness over the course of their lives. However, this is not the full picture, because we know that these data are from the United States and they may not be representative of all the prevalence rates around the world, and that's why some researchers, the World Health Organization, to compare the prevalence rates of mental disorders across different countries. And that's what you see here. They try to come up with an approach how to assess mental disorders in each of those countries. And as you can see here, unfortunately there are no countries in Southeast Asia, like no Vietnam, Korea or anything, but we have two Asian countries here, Japan and China. And the numbers you see there are quite promising, so it seems like the prevalence rates of mental disorders might be lower than in some other countries. However, it's important to remember that those numbers are also affected by stigma and shame. So it also depends on how willing people are to disclose some mental concerns. And it may be the case that in some of those countries people are too ashamed or feel too threatened and don't disclose some mental concerns that they have. And the Comparison of the prevalence rates is also very interesting when keeping those numbers in mind and then looking at specific mental disorders. You can see here anxiety disorders, and these are point prevalence rates, so how many people at any given time are experiencing such disorders. And you see that here the numbers for Southeast Asia do not differ from the prevalence rates worldwide. So about 5% of people have anxiety disorders. The picture is quite similar if you look at major depressive disorder in women. Here again, the prevalence rates are the same in Southeast Asia and other countries around the world. It gets really interesting if you look at subclinical problems, so not only clinical cases but subclinical problems, and if you look at certain things that are very cultural dependent. So I looked at some data from different Asian countries, and these are prevalence rates of disordered eating attitudes in women. So if you ask women whether they restrict their eating in order not to gain weight, for example, you see that the numbers are very different across countries, and also very high if you ask Vietnamese university students. And that tells us something about the cultural dependency of certain phenomena. And you can see that based on the culture, where your clinic is, the location and everything, the prevalence of certain mental phenomena, mental disorders can very much change. Many mental disorders affect women more often than men. And we know that women are almost twice as likely to be affected by depression or anxiety disorders than men. And the lifetime prevalence of eating disorders is 8% in women and 2% in men, so it's also much more common. We also know that women have a higher risk of post-traumatic stress disorder. And to conclude, overall, these disorders that are part of an internalizing spectrum, that I will talk to you about in a minute, are concerns that are affecting women to a greater degree than men. If we talk about the effect of mental illness, of mental disorders on a societal level, then we often talk about the concept of DALYs. Many of you may know it. DALY stands for Disability Adjusted Life Years, and one DALY represents the loss of 1 year of full health. So for mental disorders, this doesn't only mean that people are dying prematurely from certain disorders, but it also means that they are affected in a way that they can't work anymore, that they have to get on disability, for example. And that's quite interesting to see, I'll pop these all up, that there are different kinds of disorders that have the greatest societal impact on the countries there. And it starts by with these disorders that start in childhood and adolescence. Then we have autism, ADHD, and conduct disorder. And then we have this huge mountain here of internalizing disorders. So they have a very big effect on the society level of mental distress. The other categories here are externalizing disorders, and in this figure here, those include alcohol and drug abuse. And we have another fourth category here, psychosis, that includes schizophrenia and bipolar disorder. And it's interesting to point out that although this is quite like a large mountain already here, this thing, not too many people are affected by it, but those who experience psychosis often have experience a very detrimental effect on their quality of life, on their life expectancy, and so on. So what I would like to point out here is that there is a high risk for negative cascades, and it makes sense to really try to prevent or treat those disorders early before additional problems such as alcohol abuse and other externalizing problems emerge. That's something that we heard about yesterday already. I just put it also in here when we're talking about prevalence. We know that women, almost half of the women experience at least one sexual problem. And if we look at the different categories here of sexual problems in women, we noticed that those are also very prevalent, and it seems like many women in Southeast Asia are affected by at least one of those problems. How do we understand mental health and mental illness? There are different concepts, and you are the experts here in the room, you are the doctors, and I just looked them up on Google, these pictures, but I guess even though you may have another specialty as a doctor, many of you might see, okay, this is a broken leg here, this one, and the other leg is healthy, it is not broken. And this analogy helps us to see that there are parts in medicine where the all or nothing concept of illness and health, either you are healthy or you are not, makes sense, because a leg can be broken or it can be healthy, not broken. But what we find in clinical psychology, that this all or nothing principle doesn't really make sense when it comes to mental disorders. So, for example, you might see a patient who's saying, I'm feeling down for a week, I'm very irritable, exhausted, and also I've been nervous and jumpy for several months, and I don't know what the reason for this is. And maybe this patient is crying while she's talking, and she appears really stressed. And then if you maybe have some time, you decide to give her some short questionnaires, some scales assessing depression, anxiety, and so on. And maybe those scales show you some symptoms there. And then you decide, because you're very conscientious and want to do it right, you do an extensive clinical interview. And this clinical shows you that this woman does not fulfill any criteria for a depressive or anxiety disorder. And then we still have a question, is this woman sick or is she healthy? And we can't really determine this based on this very mixed picture of findings that we have. And this leads me to the conclusion that the concept, the categorical concept of health and illness does not really have room for gray areas and may not be very helpful when we talk about mental health of patients. It may be helpful in the communication, because we can then say to a patient, okay, you have this mental disorder, for example, but a dimensional view may provide much more information and may be more helpful when talking about mental health. So other ways to conceptualize this view of mental health and illness may be more like this. So on a dimension of illness and health, this woman may score something in between. So she has some clear symptoms of mental illness, of mental distress, but also has some healthy parts. And another model that is quite interesting, I think, to when we talk about mental health is this two-dimensional model. And it proposes that health is more than the absence of illness. And it includes two different dimensions. We have the dimension of mental health symptoms that patients report. But on the other hand, we have also another dimension of mental well-being. So one person can have complete mental health. So this person would report feeling very well, very positive in their life, and not reporting any mental health symptoms. Or they may report very many symptoms and also express low well-being. But what's so interesting about this model is that it also includes other aspects here. So people may experience some symptoms, some difficulties, but may also feel pretty well overall. We call this symptomatic but content. And also one person may not experience a lot of symptoms, but also not a lot of well-being, and we call those the vulnerable population. And we think that both of these groups here are somewhat neglected from research and clinical care, and those may be very important targets for prevention. I'd also like to get back to another model that Anna Maria yesterday introduced, and that's the biopsychosocial model. And I think what's so neat about it is depending on your personal profession and your view, you may see it a bit differently. So this is a room full of medical doctors, and maybe some of you might emphasize the get back to it, the biological aspect of health. While in my profession, maybe some people might say, oh, it's all in the head, it's all psychological, and may not really look at biological factors as much. Also, the perspective counts. You can talk about disorder, dysfunction, illness, or on the other hand, you can talk about what makes people healthy, what makes them thrive and achieve their goals in life. And for both of these factors, biological, psychological, and social factors count. Okay, that was a very quick introduction into concepts of mental health and illness. And now I'd like to point out how mental disorders and sexual dysfunctions are related in women. One view that I find really helpful is the so-called high-top model. If you're interested in more information, you can look this up here. I posted the paper on the slide. And the idea of the high-top model is that there is a lot of comorbidity between different mental disorders. So people tend to have more than one disorder at the time. And there is also some overlap between different categories. So certain categories of disorders are more often seen in patients together than other disorders. So at the bottom we have the DSM categories of the individual mental disorders here. And here on the top we have the high-top model. And I'd like to point to the internalizing dimension. And you see here sexual difficulties, eating disorders, fear and anxiety-related disorders, and distress. This is a category where depression also falls in. Those all fall under the spectrum of internalizing disorders. So that gives us an indication why maybe certain disorders are commonly seen together in patients. This is another way to present it. I won't go into too much detail here, but you see different disorders here, depression, generalized anxiety, for example, and all the sexual dysfunctions here on the bottom. And you see also in those arrows here that those dimensions are correlated. So those problems, distress, fear, and sexual problems often appear together in patients. And if you try to explain why this is, then it gets a bit complicated, so I won't go into too much detail here. But this is a model that tries to explain why those different disorders and dysfunctions tend to appear together. So in the middle you see sexual dysfunctions, anxiety and depression, and in the outer part of the figure you see that those may be affected by similar social or cultural norms. So maybe the social expectations that someone experiences, or the stereotypes about how women should be, how men should be, those affect all those internalizing disorders. Also, and there you are more the experts than I am, there may be some similar mechanisms on a hormonal level, on a neurotransmitter level, or overall in the biological factors. So they may share a similar etiology on the biological level as well. And then here on the left side you come to the psychological factors. And there you see that all those disorders may be affected by learned attitudes, so something that you learned in life. You learned how to respond to certain situations in a certain way. Or you had like role models that showed you, maybe your family or other peers, how to behave in certain situations. And all those factors here on the cognitive level and also on the psychodynamic level may share similar mechanisms for all these disorders. And so this may be an explanation why we see this high overlap in women who have all those different difficulties at the same time. Okay, make that a glass of water. Is this one here? Thank you. Okay, let's go to the final part of this presentation, and there I'd like to point out specific patterns. Thank you so much. I'd like to point out specific patterns of comorbidity between common mental disorders and sexual dysfunctions in women. And I'd like to start with the category that Anna Maria Giraldi yesterday mentioned as one of the key associated factors of mental health concerns and sexual dysfunctions in women, and those are depressive disorders. And we know that there is a very high overlap, and in many cases, women who have a sexual concern also experience some depressive symptoms and vice versa. For those who may not be familiar with the definition, I put the ICD-11 short description in my slides. So depressive disorders are characterized by depressive mood and loss of pleasure, accompanied by other cognitive, behavioral, or neurovegetative symptoms. And now it's important that significantly affect the individual's ability to function. So depressive disorders are not feeling sad 1 or 2 days. Or don't really having much energy for a few days. Depressive disorders are there if you really have a significant impact on your day-to-day functioning. If there's a person who maybe can't get out of bed for several weeks or so. So it's important to say that these are really clinical symptoms and not like the general moods that we may feel sometimes. We all have better days or worse days, and that's not depression. There are different depressive disorders. In some patients we see a single episode depressive disorder. Unfortunately, more common is the recurrent type. So one person who experiences one episode of depression has a relatively high risk of experiencing multiple episodes. And if you have a patient who has had 2 or 3 or 4 episodes, then it's almost certain that they will experience another depressive episode at some point in the future. We also have dysthymia or dysthymic disorder. This is like a chronic depressive mood that may not be as severe as other depressive disorders, but that lasts multiple years, so a very long time period. I may not go into too much detail here about the etiology of depression. This is really beyond the scope of this lecture here, but I'd like to point out one important correlate that I found really interesting for me. So what I like to show here, that in women, intimate partner violence, if you experience violence in your relationship, that increases your risk of depression by 3 times. And this is true for all different life stages. So they had like women from the community, women who go to a clinic to seek help, or women in the perinatal time. And for all those women who see here a higher risk of depression, this is also true for people who experience physical violence, for those experiencing psychological violence, and those experience sexual violence as well. So if your partner expresses some sexual violence towards you, maybe has sex without your consent, this is something I will cover at a later point as well. So sexual consent is something that's very, very important in marriage and outside of marriage, of course. And for all those different categories, we know that women have a very high risk of experiencing depressive symptoms. So, as I already said, depressive symptoms drastically increase the risk of sexual dysfunction, and we think that the anhedonia aspect, so the deficits in hedonic function, reduced motivation, or reduced ability to experience pleasure, seems to be closely linked to decreased desire and other sexual problems as well, and that includes sexual pain. So women with PVD have a 3 times more a 3 times greater risk of having a pre-morbid diagnosis of depression. And this relationship between depressive mood and impaired sexual function can also be found in non-clinical community samples. A history of recurrent depression is also associated with reduced sexual arousal and reduced sexual pleasure. And I'd like to point out here the additional factor of antidepressant medication. And in clinical practice, it's quite difficult to differentiate between the aversion and the side effects of medication. At the moment, we are doing a focus group study, and we are really trying to ask women who have depression and sexual dysfunction what they think the relationship between depression and sexual dysfunction is. And many women find it very difficult to point out whether it's in some part is a side effect of the medication or if it's the depression itself. So even the women themselves don't really know how those all fit together. However, there have been some comprehensive studies, and I just put this up without really knowing all the different abbreviations there, but you may be more familiar with the terms. We know that some kind of antidepressant medication, most of our SSRIs, are associated with a high risk of sexual dysfunctions, and it may be valuable in some cases to really consider other medications when a woman experiences sexual concerns and depression at the same time. So there are some alternatives that may not have a strong negative impact on sexual dysfunction in women. The second category that I'd like to point out are anxiety disorders, and those are characterized by excessive fear and anxiety and related behavioral disturbances. That means most of the time avoidance. So people avoid many situations that they are feared by them. And again, it needs distress and significant impairment to get this diagnosis. So being a bit anxious while talking to 150 very accomplished doctors, I think might be normal. And not something that would qualify for an anxiety disorder. Right? So we need a significant level of distress or impairment here. There are a lot of different anxiety disorders. Some patients have panic attacks where they think, oh, I will have a heart attack, I will faint, for example, but it's not based on medical problems, but really like just a feeling of panic. Then there are people having agoraphobia. Those may be anxious to wait in line or go through the city where they feel they might not get help in case they get panic. Then there are specific phobias. That's something I can admit. I don't really like large spiders, so when visiting Asia here, I always try to make sure I haven't seen any spider yet. But these are like specific phobias. Fear of height, fear of spiders, fear of snakes, something like that. Then we have social anxiety disorder. That means being afraid in social gatherings, being afraid of being asked questions and feeling stupid. And the last category here, we have generalized anxiety disorder. This is a category that really means you worry and worry and worry about the future, about health, about your family, about finances. And it really takes up a lot of time in the day. You really spend thinking about the future and what all the bad things are that could happen to you or your family. So I'd start with saying that anxiety disorders also increase the risk of sexual problems, but the connection is not as clear as with depression. So it's not such a close relationship as the one we found with depressive disorders. But we feel that high anxiety sensitivity, being very sensitive to being anxious, may cause women to misinterpret some feelings of arousal with anxious arousal. So if maybe your heart beats fast and you feel a bit sweaty and you get flushed, your head gets like a bit red, then you might just interpret it as, oh, I'm very aroused. Maybe in a sexual situation, you might interpret it as, oh, I'm very feeling excited for what's to come with my partner, for example. But women who have very high anxiety might interpret the same symptoms, feeling sweaty, having like bugs in your stomach and so on, as something related to anxiety. So they may not interpret it as sexual arousal, but rather something anxiety related. So this is a misinterpretation of the same symptoms other people may feel. And this kind of anxious arousal is not only related to arousal problems or problems with lubrication, but also to sexual pain. And also, women with a history of anxiety disorders are about 10 times more likely to have PVD, and worrying about the future, whether or not related to sexual issues or not, can also distract women from sexual activity and also reduce their arousal. The same is true for orgasm problems. Those are also quite connected to aspects of obsessive-compulsive disorder, phobic anxiety and somatization. And there's also some evidence that obsessive-compulsive disorder may cause more sexual problems than social anxiety, for example. The next category I'd like to quickly talk about is post-traumatic stress disorder, PTSD. And this may develop following exposure to extremely threatening or horrific events. And we know that in times of war, in times of crisis, men are more commonly suffering from this disorder, from these symptoms. But in times of peace, we know that women are those suffering more from those symptoms because they are more often the victim of other forms of violence. So those PTSD symptoms that we commonly see in our patients are flashbacks, very intrusive, vivid memories or nightmares, and that are accompanied by very strong and overwhelming emotions, fear or horror, and very strong physical sensations. And people tend to try to avoid those thoughts, or they also might try to avoid certain situations that lead them to remember their trauma. And people are often struggling with persistent perceptions of heightened current threat, something we call hypervigilance. Not all traumatic events that someone can face in life are associated with the same risks for PTSD. So seeing someone get injured or having like a car accident or traffic accident or so on, those things have relatively low risk for PTSD, while experiencing interpersonal trauma and acts of violence have very high rates of PTSD. And the risk gets even higher if you experience repeated traumas. So if you experience one act of violence, your risk is already pretty high. But if you are in a situation where you experience multiple traumas, again and again, the risk gets higher and higher. And there is a certain point, like if you have like enough trauma happens to you, then almost everyone will experience PTSD. I think it's quite obvious that such distressing symptoms are closely related to sexual dysfunction. And we know that women who have experienced sexual abuse or have been assaulted have higher rates of sexual problems compared to the general population. We also know that if you experience early trauma in the form of sexual abuse during childhood, then this has a relatively high risk of experiencing sexual problems or low sexual satisfaction later in life as an adult. It's important to distinguish here that PTSD, the symptoms that I talked to you about, is not the same as experiencing trauma. So there may be some people who experienced a trauma, had like a horrific car accident, for example, but did not develop PTSD, those have a lower risk of sexual dysfunction as compared to those who really have those symptoms. No? That's important to see, because if you have maybe a patient in your clinical practice and you know they tell you about a horrific thing that happened to them, that does not mean that automatically they have sexual problems. But you need to assess first whether this trauma also led to post-traumatic stress symptoms in the patient. So those are not the same. And an important thing that I just quickly want to point out here is that treating those PTSD symptoms is very important and crucial. So if you have someone in your clinical practice and the person has severe PTSD symptoms, it's important to try to find some help for the person, refer them to someone else, and just trying to get them the help they need. But it's not automatic that once the PTSD is treated, that the sexual dysfunction will also just go away. So I would prioritize the PTSD symptoms in those patients, but once this problem is treated and the patients feel better, you would need to address the sexual concerns as well. They just don't go away because the PTSD has been treated. Okay, and the last diagnostic category that I want to talk about is schizophrenia and other psychotic disorders. And those disorders are often characterized by significant impairments in day-to-day life, significant distress, and they are associated with such symptoms as persistent delusions, hallucinations, disorganized thinking and behavior, and an experience of passivity and control. Also, there are some symptoms we call negative symptoms, and those can be seen as blunted or very flat affect and psychomotor disturbances. It's important to also distinguish here that those symptoms have to be quite severe, and they may not only reflect something that's culturally inappropriate. So if someone behaves in a strange way that may not be appropriate in your culture, maybe talks more or is louder or wears strange clothes or so on, this doesn't qualify for these disorders. So it's not something that you can just put a label on people that are a bit unusual, but you need this part of significant impairment and significant symptoms to get this diagnosis. There are also a list of different diagnoses here, and they depend on whether you have a full picture of schizophrenia or just some subcategories of symptoms. I won't go into detail here. And we know that women who experience psychosis often have problems with arousal, delayed or no orgasm, and a lot less sexual activity and lower satisfaction. And the interesting piece here is that new research shows that sexual desire might not be affected as much by psychosis. And that may create a problem, because many women with psychosis say, okay, I can't find a partner. That's true for men also. So men with psychosis also have, many of them don't have a partner. So for many of these patients, they do have sexual desire. They want to be intimate, they want to have someone close and engage in sexual activity, but they can't really find a partner who wants to live with them and be together with them. And for this mental disorder as well, it's a bit similar to depression. The medications we use to treat those patients have often severe negative effects on the people's ability to function sexually and to find a partner. So those are just some of the side effects here: metabolic syndrome, acne, breast milk leakage, and other symptoms. Weight gain is a common problem for many patients. And all those problems together with the mental disorder itself make it quite difficult to find a partner and to really form close relationships. So those women often have problems with self-esteem and really engaging with the other gender. I would like to close this lecture with, I think, two main take-home messages. or to advise. Okay? So first, I would like to point out that mental disorders are common, they are very prevalent, and they are linked to almost all of the different sexual problems in women you can imagine. And having mental health issues can make it harder to diagnose and treat sexual problems. And also, we know this for men, but it's also true for women. Sexual difficulties may lead patients to discontinuing their medication or being non-compliant to their medication that they need for their mental disorder. So it makes sense to ask them about possible sexual concerns to make sure that they are not secretly non-compliant with their medication. So the first advice that I'd like to give is that when a woman experiences sexual problems, mentions sexual problems, try to check if those issues are connected to any other major health conditions, because it could be the case that there is a mental disorder that needs treatment first before the sexual problem can improve. And on the other hand, if there's a woman who's seeking treatment for a mental concern, like depression, anxiety, PTSD, please make sure to ask whether the medication or the disorder itself has some serious negative effects on the sexuality of the woman as well. Thank you very much. I'd like to take some questions.
Cũng có đang học và theo làm việc về tâm lý thì em có một số câu hỏi cho cô. Câu đầu tiên, nếu một bệnh nhân mà họ bị một cái lỗ quẩn là họ bị vấn đề về tâm lý, tâm thần, và sau đó thì họ bị một cái female sexual dysfunction như vậy, vậy thì đâu là điểm mà chúng ta phải cắt? Tại vì nếu không họ sử dụng thuốc rồi họ lại bị những rối loạn về tình dục phụ nữ, rồi họ lại đi sử dụng thuốc, rồi cái vấn đề rối loạn tình dục phụ nữ của họ lại tiếp tục. Vậy thì chúng ta sẽ phải cắt cái điểm đó ở chỗ nào? Vậy thì câu thứ hai nó cũng sẽ liên quan rằng có nên chăng khi mà họ chia sẻ với chúng ta là trong khoảng thời gian này tôi đang có partner và tôi đang có mong muốn hoạt động tình dục, vậy thì chúng ta có phải điều chỉnh thuốc trong giai đoạn này hay không? Chúng ta có giảm liều hoặc thậm chí một tuần hoặc là mấy ngày trước khi họ có thể hoạt động tình dục thì chúng ta ngưng thuốc sử dụng họ hay không, để họ có được cái cảm giác thỏa mãn cũng như là có những hành vi tình dục mà họ cảm thấy là happy với chuyện này. Dạ, và cái câu hỏi thứ ba là tại vì rõ ràng những người bị những vấn đề tâm lý, tâm thần kinh như thế này thì họ, trong đây cô có nói về cái gọi là low sexual self-esteem đó, thì điều này có cản trở cho việc họ không đi khám tâm lý hay không? Tại vì họ không muốn chứng tỏ rằng tôi đang bị một cái vấn đề tâm lý trầm cảm và điều này ảnh hưởng đến hoạt động tình dục của tôi cũng như là cái nhu cầu tìm bạn tình của tôi, thì họ sẽ lại ngăn trở việc họ đến một phòng khám tâm lý và gặp một chuyên gia tâm lý, thay vì họ chỉ gặp một bác sĩ sản phụ khoa hay là một bác sĩ khám cái bệnh thực thể của họ. Tại vì họ nghĩ đối với tâm lý thì cản trở họ rất là nhiều trong việc tìm bạn tình hay là có một cái hoạt động tình dục. Dạ, em xin cảm ơn ạ.
Thank you very, very much. I tried to remember all the questions, and I'd like to start by saying that I think the best way to approach this is to ask the patient what concerns are most distressing for them at the time. And it is my experiences that as a psychologist, many patients will tell you, oh, the sexual problem is distressing, but at the moment the anxiety disorder or the depression is much more affecting my day-to-day life. So they come to me maybe because they can't work anymore, or because their family said, oh, your anxiety is all over the roof, you need to do something about it. So most of the time patients will decide to focus on their mental concerns first, but I think it's crucial that we address the sexual concerns early on, because then the patient knows that we are experts and that they can approach us at a later time if they feel that now they want to talk about the sexual concern. So I leave it to the patient, And yeah, the most common response is that they would like to address the more significant mental concern first, but it's not our decision to make. They can decide, and I think it's empowering them to really think about what's important in their life if we give them the decision which they want to focus on first. The second thing is, in Germany, the psychiatrist can maybe do both, give medications and provide psychotherapy. As clinical psychologists, we don't prescribe medication. So that's not something that I need to talk about in day-to-day life, but I need to work closely with gynecologists, psychiatrists, for example, to find out the best medication for the patient. And it is my experience that people don't really think, okay, if I take this medication, it may have this effect or so on. So we need to be the experts and really know about potential side effects and explain them openly to the patient. And again, most patients may decide, oh, I'm feeling so depressed, I'm feeling so low, I have such bad symptoms that I would like to start the medication nonetheless and see how it affects my sexuality and maybe change the medication later on. But it's in most of the cases important to provide them with a good basis so they can provide informed consent and know what they are taking, and not just taking a pill without knowing about the side effects. And the last question was concerning the partner, or what? I'm sorry, maybe you could repeat it?
Câu hỏi thứ ba của em là tại vì những người mà khám về tâm lý, tâm thần kinh, họ sẽ có một cái tự tin về bản thân của họ thấp, và vì vậy cô nói là họ sẽ khó kiếm bạn tình, cũng như là những cái hoạt động tình dục ham muốn của họ sẽ bị hạn chế. Vậy thì có khi nào họ sẽ từ chối của việc điều trị tâm lý, tâm thần, thay vì họ nghĩ rằng họ trong cái mô hình tâm sinh xã thì họ sẽ nói họ có vấn đề về bệnh lý phụ khoa, họ sẽ đang điều trị một cái bệnh lý thực thể nào đó, thay vì họ nói rằng họ xác nhận rằng họ chấp nhận việc họ đang có vấn đề tâm lý và cần phải điều trị.
Okay, thanks very much for repeating the question. That's also not my experience. So I think that people who are open to talking about their mental health concerns are already, like, they made a big step opening up about something that's stigmatized, that's shameful for many people. Mental health concerns are still a stigma for many cultures around the world. So if they take this big step talking about their mental health, like talking about sexuality is only a mini step further for many. So in my experience, if people are at the point where they are confident opening up to you about their mental health concerns, then talking about their sexual health as well is something that can be integrated. So it doesn't have to be separate, but you can talk about, like, how is this symptom affecting your mental health and your sexual health, and it's something that we can address, like, in the same therapy approach. Thank you so much.
Bác sĩ ạ, đơn vị rất là nhiều công việc nghiệp vụ. Có một chia sẻ một cái case lâm sàng ở khoa tôi gặp một bệnh nhân đến khám vì không đạt được cực khoái. Bệnh nhân than rằng là bệnh nhân lên Tinder là đã quan hệ với 100 bạn tình nhưng không bạn tình nào đạt được cực khoái. Bệnh nhân muốn là kiếm một bạn tình khi mà đạt được cực khoái thì mới có thể cắt kết lâu dài. Thì bệnh nhân tới khám thì bệnh nhân rất là hoang mang, không biết rằng là bệnh nhân có vấn đề về phụ khoa hay là vấn đề về rối loạn tình dục. Thì liệu rằng như vậy thì đối với bệnh nhân này thì chúng ta tiếp tục giữ bệnh lại để chúng ta tư vấn về rối loạn tình dục, hay là bệnh nhân chúng ta chuyển bệnh nhân tới nhà tâm lý và nhà tâm thần. Tại vì là bệnh nhân nói rằng lên Tinder là bà quan hệ tới 100 bạn tình. Thì như vậy thì cái này là nó thuộc về dạng của rối loạn tình dục hay là rối loạn tâm lý hoặc tâm thần?
Okay, thank you very much for this interesting case. I think just from a perspective as a woman, if you want, if it's your goal to get an orgasm, then it's not the best strategy of trying out 100 different partners. That's usually not how it works. I think while I can't diagnose the patient here because I haven't seen her, I think the main question that I would ask her at this point is whether she is able to reach orgasm by herself or not. And that gives us a good indication whether there may be like a physiological or a medical problem or whether it's psychological or interpersonal. And like for me it would also be important, having 100 partners may not be a problem at all. So in some cultures it's highly sanctioned and women who have 100 partners are frowned upon and not respected, for example. But from a psychological perspective, if she's feeling good with it, then go for it. So it may not be a psychological problem, but it may not be an effective strategy for her to reach her goal of achieving an orgasm. So as a psychologist, I would try to understand what she's looking for in all those partners, and I would try to make sure that she's safe, so that she doesn't get in unsafe, risky, dangerous situations with those men. And then try to work with her alone with some of the strategies that I will show you in the next lecture, and try to figure out what she wants and how she can stimulate herself. And then if she knows how to reach orgasm by herself, then we can talk about how can we communicate this to a partner. Thank you.
Well, hello. Well, postpartum depression is a type of depressive disorder that affects some women after giving birth. Studies show that this affects a significant percentage of Vietnamese people, Vietnamese women. Well, for ordinary people, can they recognize the symptom? Well, can you show me the observation, treatment, or therapy?
Thank you so much. I didn't get the first sentence because I had the I think it would be, I'm not sure if we already talked about postpartum. No, I think Faisal, like the presenter this afternoon, may talk about it. And I think it's crucial to include questions about postpartum depression at the regular follow-up visit after pregnancy. I'm not sure if that's standard in all the places where you live, but if you see a gynecologist after giving birth, it's very important to include at least a few questions or questionnaires about postpartum depression. And it's also important to take this seriously because we know postpartum depression is a risk factor for developing postpartum psychosis or developing depression later on. And so it's very crucial to not tell the women, oh, it's going to get better, it's just the lack of sleep, you're going to do fine, but really try to figure out what she needs and give her the support, or try to figure out if she has the support system with family and so on to support her during this difficult time. I hope the doctor that will present this afternoon will also provide more insight from a medical point of view concerning postpartum depression. That's how we approach it as psychologists. So most of our treatments for postpartum depression are not directly after giving birth, but after a few months when women have tried other things first. Because psychotherapy takes a bit of time, and if you have a newborn at home, it might be difficult to concentrate and find someone else to take care of the baby while you go to therapy. So most patients we see have already suffered from it a few months. So the gynecology practice is the first professional who should take a look at possible depressive symptoms after birth. In my opinion. Yeah, of course.
So from the psychiatric point of view, I agree with Dr. Velten that it's so important to identify them. And where I come from, we have these small questionnaires that you can screen them for symptoms, and we take it very seriously because we know it's also for the baby, the contact with the baby, how to take care of the baby is so important. And we actually start them on medication if they have a postpartum depression. As you say, not just say, oh, it's going to go over. We have many bad cases with women being very, very severely ill, very severely diseased. So we will put them on SSRIs, most likely the ones that you can use if you don't relax it.
Hỏi thứ nhất đó là bác sĩ nói là cái vấn đề mà bệnh mẫu với lại trầm cảm thì ở trên thế giới là nữ nhiều hơn nam. Thì không biết là ngoài cái yếu tố xã hội, yếu tố gì khác đó, còn yếu tố gì giới tính nó có ảnh hưởng gì không? Ví dụ như phụ nữ phải chăm con cái gia đình, mặc dù là khảo sát ở những nước phương Tây thì đàn ông nó có vai trò trong chăm sóc con cái nhiều hơn phụ nữ. Thì không biết có phải vấn đề kinh nguyệt hay bệnh lý gì, phụ khoa vân vân mà nó làm cho ảnh hưởng đến vấn đề mệt mỏi và trầm cảm của phụ nữ cao hơn nam giới. Cái câu hỏi thứ hai đó là cái hội chứng mà chấn thương tâm lý, chấn thương mà gọi là hội chứng rối loạn tâm lý sau chấn thương đó, thì là bác sĩ nói là xin lỗi, nhà tâm lý này nói là mình điều trị vấn đề tâm lý nhưng mà cũng chưa chắc gì hết đâu, cũng phải kết hợp với điều trị khác. Còn thực ra khi mình sau mình khảo sát mình nghĩ rằng tâm lý là ảnh hưởng đến vấn đề rối loạn chức năng tình dục, thì chuyển sang bác sĩ mà về phụ khoa hay là bác sĩ khác đó mà điều trị thì điều trị cái gì? Bởi vì đa số là do ảnh hưởng tâm lý. Vậy cái vấn đề đó nó có làm cho co thắt âm đạo hay không, hay là vấn đề ví dụ như mình cắt cái tiền đình đó, mình tạo hình tiền đình nó phải làm giảm cái bằng vấn đề tình dục nó tăng lên hay không? Cảm ơn.
Those are, again, very wonderful questions. Thank you so much. The first thing that I'd like to point out that we can't really leave the biopsychosocial model. So there is not one, like the one best reason for why women experience more depression than men. So it has to do with biology, of course. It also has to do with the societal expectations, the roles that women have in society, and it also has to do with psychological factors. And that is one of the critical things that we try to figure out in our history taking when talking to the patient, what the crucial factors for this individual person are. If it's like a medical and hormonal problem, or if it's in the relationship to the partner, or maybe in the family situation. So even though we know that all of these factors, biological, psychological, social, are important on average, we don't really know how it's for the individual patient. So we need to look very closely and see what factors are relevant for this individual person. Concerning PTSD, in where I come from, it's like most people say, okay, before we treat PTSD, we can't really do anything else with psychotherapy and psychological problems, because those patients are so distressed, they are so experience so much suffering from their PTSD that this comes first. And the other thing then is to, like, as a psychologist, to be a bit brave and to take courage and really try to work with those patients on their sexual concerns once they feel better. Because many patients just say, many therapists or clinicians say, oh, this is such a fragile person, she's suffering so much, we can't really talk about sexuality. That's too much. That's too much for her to handle. And they neglect the sexual part because they say it's not important enough. The trauma, the PTSD is important, not the sexual concerns. She will do fine. It will go better. But many patients with PTSD have avoided sexual contact or have dissociated during sexual contact. They've just, like, they did the chores, their body functioned as expected maybe, but they were in a different place in their head while doing sexual activity. They just dissociated. And so that what we need to talk to patients is trying to own their body again, feel good in their body, and then be confident again to approaching maybe a partner being sexually active again. So in my perspective, in many of the cases, we wouldn't necessarily need surgery or other medical interventions, but of course we always need to check. So we always refer patients to a gynecologist, to a psychiatrist, to other medical professionals to really check if there is like physical trauma, for example, if they are hurt, if there are other things that need to get addressed from a medical perspective. Thank you.
Vâng, cảm ơn một bài nói rất là sâu chuyên về sức khỏe tâm thần và tâm lý. Chúng tôi thực hành trong lĩnh vực phụ khoa và vô sinh thì có một số cái vấn đề. Thứ nhất là một người vô sinh họ mong con, họ chờ đợi cái kết quả của quan hệ hay là của con, chứ đôi khi họ nghĩ đến cái chuyện thỏa mãn. Và chuyện này nó có thể kéo dài thời gian dài và có thể ảnh hưởng đến tâm lý tình dục. Cái này thì chưa thấy tiến sĩ đề cập. Cái thứ hai là trong phụ khoa chúng ta có một cái bệnh cảnh là cái giảm dự trữ buồng trứng và hoặc là suy buồng trứng, là một cái tình trạng sụt giảm cái nồng độ estrogen rất là nặng. Và estrogen là được coi như là một cái năng lượng chính cho người phụ nữ. Nó không chỉ là ở thể hình mà nó kể cả trong cái tâm lý tình dục. Như vậy cái tình trạng của thiếu hụt kéo dài nó có thể ảnh hưởng đến cái ham muốn và nó ảnh hưởng đến cái sự thỏa mãn một cách đầy đủ. Cái thứ ba là một số cái đặc điểm của người phụ nữ nó có hội chứng buồng trứng đa năng, cũng là một cái tình trạng rối loạn nội tiết nặng và nó ảnh hưởng đến cái thể hình béo phì, lồng lông, cái béo bụng vân vân, thì có thể nó gây những cái cảm giác tự ti trước bản thân và nó sẽ ảnh hưởng đến cái tâm lý tình dục. Và những cái này nó là một dài, có thể nhiều tháng, nhiều năm rồi. Và cái kết quả tình dục thì chúng tôi nghĩ rằng nó ảnh hưởng rất là lớn. Và như ngày hôm qua cái bài đau trong quan hệ vậy nó cũng là một cái trở ngại. Như vậy chúng ta có thể nói theo một chiều suối thì những cái này nó có thể góp phần vào cái kết quả của cái cuộc quan hệ một cách hiệu quả. Xin hỏi tiến sĩ một cái cách ngược trở lại thì cái kết quả của một quan hệ nó không hiệu quả sau một thời gian dài, nó lại ảnh hưởng ngược trở lại tâm lý người phụ nữ, nó làm cho họ lo lắng và trong sau thời gian dài người ta bị căng. Như vậy cái việc nó tiếp cận nhất đối với văn hóa Việt Nam thì mà chắc cũng như đấy thì người ta cũng như đồng thuận với cái bàn nông nghiệp đầu tiên, người ta sẽ không để mình bị họ bị trầm cảm hoặc bị lo lắng căng thẳng nặng nề về mặt tâm lý, họ bị cái nào đâu. Chúng ta phải là người tìm hiểu, chúng ta phải là đặt lại cái vấn đề từ đâu mà ra. Như vậy cái gì của trước chứ chắc là tâm lý của trước có thể là cái vấn đề tình dục của nó dẫn đến cái sợ hãi, nó dẫn đến một cái cuộc quan hệ nó thành công. Một câu hỏi tiếp theo là như thầy Thương có đề cập đấy, bây giờ chúng ta có những cái ngưỡng cắt bộ công cụ sàng lọc mức độ trầm cảm hoặc là căng thẳng lo lắng, và thường là chúng ta ở mức độ mà nhẹ, ví dụ Hamilton hay là những cái bộ câu hỏi khác mà nhẹ thì những bác sĩ phụ khoa cũng có thể tư vấn, bác sĩ tâm lý tư vấn. Nhưng mà nếu nặng thì chúng ta phải chuyển cho bác sĩ tâm thần. Như vậy là đến mức mà trầm cảm hay là như những cái lo lắng, sợ hãi, những người mà có ác cảm tình dục như là tiền sử quan hệ bị hiếp dâm chẳng hạn. Như vậy thì trong thực hành chúng ta sẽ dùng cái gì để mà có những người cắt ở đâu đi ngắn, không thể ở đâu là phải điều trị thật sự. Thật sự đấy là một cái vấn đề rất lớn mà rất sâu, sẽ rất thường gặp. Cũng mong tiến sĩ sẽ chia sẻ thêm cái nội dung này. Xin cảm ơn.
Okay. Thank you so much for these wonderful questions. I tried to remember most of them. So you started with asking about infertility treatments, and the patients that I see are often those who have already done like their infertility treatment and then had an outcome, a positive or a negative outcome, and then after a few years notice that their sexual life is really distressing for them. And I haven't seen too many patients with after infertility treatment, but what I saw isn't really that encouraging, because for many couples, if they have to schedule sexual activity and everything is focused on the baby, they really lose connection to their own desires, to their own body, and both of the partners, men and women, can develop significant sexual concerns. So I had one couple coming in many second, and they really, we determined after talking to each other that the woman really doesn't have a lot of desire for sexual activity, and no matter what we did, what we tried, we couldn't really improve the situation for her. But what we could do is we could work with the couple, with the man and the woman, finding out ways for them to get close again, to experience some tenderness, closeness, and also find some ways that were okay for both partners to really satisfy the needs of both persons. So they found a routine that worked for them, where the partner got satisfied and the woman got the tenderness and closeness she desired, but really decided that at this point in her life, being sexually active wasn't really for her anymore. This is one case. There may be many different, more positive outcomes, for example, but what I can say from my clinical practice that it greatly affects couples who have multiple years of going through those treatments and having all these impacts on the body of the woman and the sexual interactions. The second question was, I'll jump to the referral aspect. I think it really depends on the capacities and the system you have at the place where you work. Whether you can consult a other healthcare worker, a mental health professional, a psychologist very early on, or if it's another process. So I would encourage you and your teams maybe sitting together and finding good ways to integrate the different professions, and then work together with the patients and ask them how they want to proceed. It really depends on whether it's covered by healthcare or if it's really expensive at the place to get psychotherapy, for example. If there is qualified people doing it, not all the places may have qualified clinical psychologists available, and you really need to figure out how to work together with other professions at the place where you live. And that's what we try, at least in the clinic that I work with, that I work closely together with other doctors and trying to determine if there are medical causes that need to be addressed first or at the same time as the psychological causes. I think if I look at the time, it's good if we jump to the next lecture, right? Okay, thank you so much. I will take another sip of water and then...
Dạ, em
Okay, I'll start with the next lecture. And in this lecture, I'll cover some content concerning to male sexual dysfunctions. And then this